All right, we are going to try this video on palliative care. So palliative care is the holistic approach to care or treatment at the end of life. And it really should start, palliative care should start upon the diagnosis of a severe disease or symptom and should move from there. Palliative care is best provided through an interdisciplinary team, and that team includes the physicians, social workers, pharmacists, advanced practice nurses, the chaplain. The chaplains play an amazing role in this, as well as the social workers. They provide such emotional support to these families. It is unbelievable. And then we have the CNAs, the physical therapists, and many, many others. And there is continuous alignment of these team members throughout their care, and this care can be delivered in the extended care facility, the rehab facility, the nursing home, and the hospital, and any floor in the hospital from obviously not in the ER. These patients do visit the ER, but they can also be on a med-surg floor to the ICU. The goal of palliative care is to prevent and relieve suffering and improve the quality of life for patients who often have severe cancer. Palliative care does not necessarily mean that they are terminal, but it means that they are having symptoms that are very debilitating for them. So hospice is the concept of care that provides compassion, concern, and support for patients that are dying and for their families, and extended care, or extended families as well. And so hospice is the goal to not pursue a cure, and we want to emphasize really on a good, dignified end of life. So hospice exists to provide care for patients in their last phases of a terminal disease. And again, it could be in home, it could be in an inpatient hospice facility, and it could also be in a long-term care facility. And there are freestanding hospice facilities. I think there's like 5 or 6 in this area. And patients can have hospice at home. And then if their pain is getting too out of control or the family just can't handle it, they can be moved to an inpatient facility. So about 42% of the patients who die in the U.S. are under the care of a hospice program, and 1/3 of these are over the age of 85, and 40% of these do have a cancer diagnosis. The average length of stay is 21 days. These patients can be in for up to 2 years, and they are renewed, I believe, every 3 months with this diagnosis. So admission has 2 criteria. The patient must want the services, and they must be eligible for the services. So 2 physicians need to certify that the patient has 6 months or less to live. Usually one of those is the admitting director of the hospice and then the patient's own referring physician. So on this question, the nurse explains to a patient with advanced cancer about the differences between hospice and palliative care. What do you think the answer is? Correct. C. Hospice care will help me and my family prepare for death. I deleted these out of here. I don't know why this is still showing up. I apologize. I took the case study out so that it would go faster. So death occurs when all vital organs and body systems cease to function, and it's the irreversible stopping of cardiovascular, respiratory, and brain function. Brain death is the irreversible loss of all brain functions, including the brainstem, and it occurs when the cerebral cortex stops functioning or is destroyed. The exact definition of death can be controversial. You'll remember in the news about 4 years ago, there was the 13-year-old who had her tonsils removed, and she ended up bleeding, and she became hypoxic and was pronounced brain dead, and she is now in a private care facility. She's the only one in the nation. In the 1970s, brain death is the same equivalent as death. So end of life refers to the final phase of a patient's illness when death is imminent. It's the period of time from diagnosis of the terminal illness to the actual death. The IOM, the Institute of Medicine, defines end of life as the period when they start declining, and it can be with advanced age, and it doesn't necessarily have to be that death is going to happen immediately. So someone who has severe COPD and they're just tired and they don't want treatment anymore. or we're going to start weaning them off some of these treatments. So end of life is used for the issues and services related to death and dying, and we focus on the physical and the psychosocial aspects of the patient and their family. And we spend the whole team, that whole multidisciplinary team that we talked about, spends a lot of time with the family. Social services and chaplain are wonderful here. The nurses are great too. However, the chaplain and social workers are great at this point. Our goals are to provide comfort and supportive care for the patient and their family during the dying process, improve their quality of their remaining life, help ensure a dignified death, and provide emotional support to the family. So what happens at the end of life? Everything slows down. Our body gradually slows down until all function ends. And then respirations usually stop first, and then the heart stops beating, usually within a couple minutes. Sometimes, if it's a really active person who was younger, it can be up to 5 to 8 minutes. So then we're going to now go through the body systems. And so respiratory, usually we have irregular breathing, which gradually slows, and then we have the chain-stoke breathing. And chain-stoke breathings are the respirations that can be really rapid, and then they slow, and they become really shallow, and then they can become really irregular. And I will post a video for you of some chain-stoke respirations so you can see what they look like. We talk about the death rattle, and that is really, really hard for families to hear. So we have so many medications that we really need to administer for these patients so that families don't have to suffer the death rattle. It is something that will impact them for the remainder of their life, and that's not something that we want the family to have to deal with. The same thing applies in the hospital. There are medications and protocols that these families should not have to deal with. It's the grunting, gurgling, or the noisy, congested breathing. It's like a, and they don't need that. We can dry up those secretions, and they don't have to hear that. As they're slowing down and the respirations are starting to end, we call it guppy breathing, and it really looks like they're guppy breathing. So chain stokes, they can have alternating periods of apnea, and then they have fast, deep, rapid breathing. So hearing and touch, hearing is usually the last to go. I can tell you when my mom was on hospice, she had been comatose probably for about 18 hours, and the chaplain came and the social worker was there, and we were standing around her bed and we were saying a prayer, and the nurse said, Noni, are you seeing the angels? And my mom's eyes just started blinking, and that was very comforting for us. So they do have a decreased sensation and decreased perception of pain and touch. Do we actually know how much they can hear? We're not sure. And the ethical aspects of, doing studies on that, we're not sure. So they talk about having a blurry of vision. The blink reflex is absent, so if you tried to do that neuro test, it's not going to be there. The patient appears to stare, often into the distance, and the eyelids can remain half open or closed, and they have a decreased sense of taste and smell. Sometimes they can be awake, and they can have different appearances and periods of lucidity. Skin, why do they have a shift? Where is all the blood flow going? Remember, our body is doing the fight or flight, so our body is still responding, and our body is going to send all of our blood to the essential organs. So it is going to my heart and to my brain. And so that's why my skin is going to have some modeling on the hands, feet, arms, and legs, and my skin is going to be cool and clammy, and it feels kind of waxy. The skin cools first on my lower extremities, and then my upper extremities, and then finally on my abdomen. And I do get cyanosis of my nose. My nose gets kind of a purplish color, and then my nail beds, my knees, and then I talked about the wax-like appearance. Urinary system, there is a gradual decrease in the urinary output, and once this actually starts to happen, you'll see a change in color. And there is a prediction from the time that there's a change in urinary output that when death will be imminent and when it can happen, from hours to days. They can be incontinent of urine, and they often can be unable to urinate. GI, some of the drugs we give can cause them to have losses of their GI function. So They can get distended, they can have nausea, and they do have nausea medications on board. So it seems counterproductive, but we are giving them medications to control pain. Death itself is not painful, but we're giving them medications to help with their breathing and to relax some of the smooth muscles to make breathing a little bit easier for them. So we have a loss of sphincter control. So we call it their terminal bowel movement, and that can happen right at death because the loss of the sphincter, or it can happen right after death. And it can be a small amount or it can be a very large amount. And so because of this slowing, everyone thinks that they need to eat, and they try to get them to eat, and they're like, they're not eating. And we just need to let them know that everything slows down as patients are nearing that end of life period, and it's okay. And it can be, 3 days to 10 days that this process is happening. Musculoskeletal, they're going to have loss of ability. They're going to lose tone. And they lose tone everywhere. So we start seeing sagging of the jaw. We're going to have some slurring of the speech, some garbled speech, a loss of the gag reflex. So with that, obviously, we're not going to want to be giving them liquids. We're not going to be wanting to even give them a parade diet, and swallowing can become more difficult. So with this, at some point, because everything slows down, they don't need to eat. And it's not painful because the metabolism slows down, the body takes over, and they don't need the nutrition. And we don't need to do an IV fluid because they're going to have enough stuff already. Cardiovascular, it's part of the brainstem function that we initially see an increase in the heart rate, and then as death becomes more imminent, we start to see a slower heart rate and the weakening of the pulse. It becomes very irregular. Obviously, we see a decreased blood pressure, and because of the vasoconstriction and the modeling, we don't really want to do IM or sub-Q, and that's why we give a lot of sublingual medications. So, end of life, patients have a lot of, we want family members to come in and say their goodbyes. This isn't the time that we're planning our will, planning out our estates. End of life can bring anxiety and fear. There's a great process called a life review. And a lot of times when you go on for your bachelor's, this is something that you actually do with someone who's 70 years or older. And they reminisce and they remember fabulous memories from childhood all the way through, and it goes through Erickson stages, and it's wonderful. There's a sense of peace, and sometimes for those estranged relationships, people are able to have their final goodbyes. Sometimes it's sad. These people are entering hospice, or they know the doctor told them that they only have 2 months to live. So people come in, and it's a very fragile time. And so you're crying and you're saying your goodbye, and they're fully awake and alert, and it's really hard. And sometimes they get depressed, and it depends upon their faith and their strength and how things work. So it's a very delicate time, and we have to remember what's best for the patient. And sometimes we have to step in and remember what is best for the patient, and remembering that we are the patient's advocate here and the family's advocate, and their coworker who they haven't seen in 50 years, maybe they don't need to come today, maybe they need to come see them tomorrow. So bereavement can start when the death happens, and hospice actually has a program in place that they follow them from 1 year after the time of the death. And so hospices are fabulous at making sure that these people have great grief counseling in place, and that they actually move through the grief process in a good state. Grief is a normal process reacting to the loss, and we want to move through that. And there's the stages of anger, guilt, sadness, depression, and despair. And all those symptoms can happen with changes in someone's sleep pattern, appetite, physical problems, illness. And then we have the unanticipated grief reactions that are not so healthy. So we talk about Elizabeth Kubler-Ross's grief patterns, and we have denial, anger, bargaining, depression, and acceptance. And, sometimes people can jump from denial to depression to anger, then they can go back to denial. So there's no true process of how these people go through this. There's another model called the model of grief, and they can go into shock. They end up going into this shock right here, and then they stay in shock, and then they hit this area of protest, which is kind of the denial, and then they live in this area of disorganization. And I know someone, her mom died 8 years ago, and she is still in this area of disorganization. She just can't move past it. She's kind of a dysfunctional person anyway, and she just hasn't gotten to this reorganization phase. She bounces back from disorganization to protest, and it's really a shame. So anticipatory grief, this can happen to caregivers, to nurses who work with this for a really long time, oncology people. It happens to oncologists too. And then people can experience it at the end of their life. So someone who knows that someone has Alzheimer's, once they're diagnosed, they kind of start having this anticipatory grief too, knowing that, eventually they're going to lose the loved one who they have currently. So adaptive grief is accepting the reality of the death. It's a healthy process, and we start having those really good memories. Dysfunctional grief, we talked about that, and it really holds people back. Grief support, we mentioned this. Spiritual needs. People don't necessarily have to have a belief in a higher power, and we respect that. Some people choose to meditate. Some people believe in their own, and it's up to the family. Some people don't even have funerals after their loved ones die. They have them cremated, and that's it. Some funerals are just the family. Some people just have their loved ones cremated, and that's it. There's no ceremony, nothing. So there's some pretty interesting things that can happen. Others, there's a whole funeral process with the wake, the funeral, the burial, etc. So a lot of times when patients are nearing the end of life, they question everything about their life, and are they going to heaven, or are they going to end up in purgatory? And then they go back and they want to make amends. So we want to make sure that they're not in despair at the end of life. And this is really when the social worker and the chaplain come in, and they are very well versed at this. So culturally competent care, we want to make sure that we are very aware of how people handle death at the end of life. Some cultures wail, they scream, and this is very normal. I have been exposed to this many times. One of my friends working up at Northwestern, a specific type of Judaism, when the patient died, they had to be placed on the floor facing east. And so the second the patient died was pronounced by the resident, they had to pick the patient up with no sheet and place him on the floor. And then the eldest son stays with that one person until someone from the mosque can come and stay with them. And then there's a cleansing of the body, etc. So it was a pretty interesting thing to hear what she got to experience. Sometimes there's rituals. There's a washing of the body. They wrap the body. There's oils, etc. Some religions, patients are cremated, and it's the eldest son who, or the eldest relative who actually, they do a ceremony, and the eldest son or relative pushes the cremation button. It's really interesting. So nurses just need to have a awareness and references for culturally competent care, and again, open-ended questions. And we want to really have an idea of our nonverbal cues and guide it from there. Legal and ethical issues, again, every death has to be reported to the National Organ Donation for your area, and hospitals are very specific with this. So, donating eyes, corneas, skin, tissue, long bones. Hospice patients can do that. Do they have advanced directives? The resuscitation. Obviously, most patients who are going into hospice are a DNR. But organs and tissue recovery banks have to be notified of every death, and that is a federal law. Legal and ethical, we talked about this, advance directives, power of attorneys, etc. And resuscitation, we talked about full codes. Chemical codes mean that we are not going to do CPR, but we're just going to issue drugs. This kind of takes the legality out of the family. The family doesn't want heroic measures done, but they don't want to feel like they didn't do anything. So they don't truly understand the process. So we just push drugs and there's no CPR. So the families feel a little bit better about that. And so we just kind of do comfort measures. And then euthanasia. The United States does not practice legal euthanasia, except for the state of Oregon, where if you have a terminal diagnosis, it's declared by 2 physicians. And there was a woman, she was 32, I believe, and she had a brain tumor. And when the time came and she was no longer going to be able to be self-care, she took enough pills and she was able to self-euthanize. So again, the ANA, the American Nurses Association, says that nurses should not participate in this. So withholding artificial nutrition, this would be something that is taken care of with an advance directive, with a living will. So nurses spend more time with the patients at the end of life than any other healthcare professional, and we really, really provide great care for the families at this time. We provide holistic care, and we really focus on the physical and the psychosocial aspect of this with the patients and the family. The assessment, it really depends on the patient's condition. Obviously, if the patient is comfort care in that we're not in there assessing them every 2 hours, we might assess them every 12, every 16. The hospital might have a policy and the physician's order can override that. So we are not in there interrupting the family's private time. If the patient's alert, we might just do a quick assessment of orientation and assess them, obviously, for pain, nausea, and shortness of breath. The frequent assessment, again, like I said, we're just doing essential things. So your 10-minute assessment here is not something in the end of life that has to be carried out all the time. And it's driven by the policies and procedures of your institution. As death approaches, we're going to monitor for those changes. Pupils will have decreased responses. We're going to have those changes that we talked about in skin color and vital signs, changes in the respirations, changes in GI and GU. And as this death is more imminent, the skin is going to start to shear. So different nursing diagnoses are going to come, and they're really going to relate more to the psychosocial and spiritual that come with the patient and the family. So really, we're worried primarily about the patient's needs, if they are alert, and what's going on with them, and then the family and their significant other's needs. And we really want to provide great support for them and teach and evaluate. So comfort measures, most patients who are brain dead are in the ICU, and then if they become comfort care and a bed is needed, we try not to move them out, but sometimes in a high trauma area, we might need to move them out. When I worked at Northwestern, we had only a palliative care floor, and it was nice because it was just a very serene floor where those patients were able to go. But we try not to move them, especially if they were in the unit for like 3 weeks. And we ask the patient, where would you like to die? Do you want to die at home? Do you want to die in the hospice facility? Where do you want to die? And some of the patients are like, you know what? I want to die in Hawaii. I want to die in Aruba. And they don't want to die in their house because they don't want their family member to have to do that. Psychosocial, give them as much information as they can handle. Again, a lot of anxiety and depression because they have uncontrolled pain. And remember, we talked about pain causing extra anxiety. And we can manage that. Good education. Surviving family members can become angry, and then there's a lot of issues that happen with this. And you as the nurse can be the target of that anger, and it can be pretty blatant, let me tell you. So one of our nursing goals can be hopelessness and powerlessness. Nursing diagnoses. And this is very common. So we want to just help them be realistic. So 4 specific fears is that death is painful. They're going to have shortness of breath. feelings of loneliness and abandonment, and that their life was meaningless. And so we want to help them have coping strategies. Pain. Many assume pain accompanies death. There's no indication that death is painful at all. There's more psychological pain based upon the anxieties that death brings. Terminally ill patients have many pain-relieving drugs available, but the vital sign changes are not showing that they experience pain. It's the brain processes of the body shutting down. The pain medications provide grogginess and some sleepiness. We don't want to overdose them so that they can't interact. They do get some air hunger because of the shortness of breath, and that really provides anxiety for the patient and the family, and we can give them the drugs because some of the drugs are bronchodilators. We can give them oxygen and help them do that. We can give them anti-oxalytics, anti-anxiety medications to help reduce the anxiety. They don't want to be left alone. They don't want to die alone, and they don't want to leave their loved ones alone. And they want someone to be with them when they die, sometimes. The fear of meaninglessness, and they want to know that their life had meaning. Communication, open communication with everybody. And we let them have time to talk. Obviously, if you work on a busy med-surg unit, you don't have time to talk with them continuously. So we need to be able to allow them time to talk, and then we can come back and set some limits and come back and talk with them again and again. If you work in a hospice facility, this is a little bit different. End-of-life considerations. We can have silence. Silence is often a good thing. We don't always have to say anything. And just listen to the patient. Patients sometimes end up getting confused, and remember, their speech can be garbled. We treat their symptoms. The big one is to meet their physiological and safety needs. Just maintain their integrity. So when the patient dies, we want to close their eyes. We want to put their dentures back in if they're going to be embalmed, if they're not going to be cremated, because once the body is embalmed, those dentures cannot be put back in. And then we freshen up the body. We remove all tubes and dressings. Obviously, if it's a hospice patient, the coroner is not involved, and we don't have to call the coroner to get a release of the body. And then we straighten the body, and then we put the pillow under the head, because we don't want the head to be discolored for the embalming of the body. And then we follow the institution's policies and procedures. Most of it is that we want to get the body to the morgue or to the funeral home to get them cooled or embalmed as closely as possible, because rigor mortis will set in quickly, and then it is more difficult for the morticians to set the body to be presentable. So families don't get 7 hours to sit with the family in the hospital. We try and help them have as much time as they can, but they don't get 6 hours. So we work with the family, and we're supportive with them. And we have to, we try to work with them, and again, disgruntled situations and things like that. Give them as much grief support as we can. And nurses have feelings too, and they can become compassion fatigued, and it's okay to cry when your patient dies. It is very okay. And it is okay to go to the funeral if the patient meant something to you, and to have that closure. I have been to many funerals, I've been to many wakes, and that's okay.